Welcome to today's presentation, What COVID-19 Taught Us About Our Healthcare System. This presentation is part of Northwood University's Freedom Seminar, and it is discussing ways in which the Northwood philosophy applies to issues of the day, the big issue of today obviously being COVID-19. And we are pleased to have with us today Grace Marie Turner. Grace Marie Turner is president and founder of the Galen Institute. Galen Institute is a nonprofit that does research, good research and advocacy on behalf of patient-centered healthcare and public policy. And she's here to tell us today about the ways in which the current crisis has helped us to better understand the way our healthcare system works, perhaps some of the ways it could be improved. And so I expect it to be a very enlightening conversation. It's a complicated system, but nobody understands it better than she does. She is the president of the Institute, which she's also the founder, which has been here since 1995. She's been instrumental during that period in developing, promoting ideas for reform that transfers power over healthcare decisions to doctors and their patients. She's an extensive writer and speaker about incentive-based healthcare systems and promoting competition in the healthcare sector. She's frequently testified before Congress and advises senior government officials, governors, and state legislatures on healthcare policy. She was a member of the Long-Term Care Commission and Medicaid Commission. She's been published in hundreds of newspapers, including the Wall Street Journal, the New York Times, USA Today, frequent appearances on TV, including ABC's 2020 and other hundreds of radio and television programs. She's a co-author of Why ObamaCare Was Wrong for America, published in 2011, and the editor of Empowering Healthcare Consumers Through Tax Reform. So please welcome Grace Marie Turner.
Professor Radchak, thank you so much for that introduction, and it's a pleasure to be with you and with all of our participants and your students. I wish we could be together in person. I'm hoping that we will approach some sort of a new normal where that's possible in the future. There are all sorts of benefits of being able to talk with one another face to face, eye to eye, but this is a great substitute for the time being. So thank you very much for inviting me to be on and part of this really terrific overall 3-day program. So you've asked me to talk about what COVID-19 has taught us about our healthcare system. And just a kind of very quick overview is I think it has really taught us a lot about the generosity and the goodness and the strength of America. You really do see what a people in a country are like in a crisis. And as much as we are freedom-loving people, most people early on, when it made sense, really did abide by the voluntary guidelines to stay home. Now that people are seeing that we need a more sophisticated, targeted approach to opening up our economy as well as continuing to fight this pandemic, I think you start to see much more pressure from freedom-loving Americans to really get our economy going again. So I'm going to talk about that, but I'm also going to talk a little bit about what we have seen in our health sector in particular and what we have learned about it through the response to this crisis. And I think one of the things that we're finding is that we need a better balance between government and the private sector. And what we see is that where there have been successes, it's mostly been in the private sector. Where there have been failures, it's from government really overreaching and really having too much of control without the resources to really make the difference and to be able to produce what was needed. So let's talk first about the importance of deregulation. We have seen the Americans for Tax Reform has a website at atr.org that has tracked the number of rules and regulations that have been eliminated, relaxed, waived because of the pandemic. They're up to now 485 federal and state regulations that have been waived as a result of the importance and imperative for being able to respond quickly to this pandemic. We're all, of course, aware that telehealth is becoming much more prevalent, so you could actually see your doctor without seeing your doctor, and having payment systems that will support that, allowing companies to go to people's homes to do testing and being able to be paid for that. Acceptance of cross-state licensing. So a doctor that is licensed in Colorado can actually practice in New York City, where there has been a concentration of people that have needed care. Wider scope of practice. For example, licensed pharmacists that under a lot of federal rules are now able to order and administer COVID-19 tests. So that pharmacists certainly have the capability to do that, but now the payment systems and the protocols and the licensing will allow it. Importantly, they've also realized they had to eliminate a lot of paperwork requirements for doctors and nurses, that it was taking too much time away from patient care, too cumbersome. Allowing manufacturers that were not a part of the pre-approved, long, cumbersome process of being approved as a federal contractor, allowing them to be able to produce masks when we were in a hurry to get them. So the 3M, which has the capability but hadn't really been a mass producer for the federal government, was able to turn out millions of N95 masks. Alabama was one of the first states to allow curbside pickup of alcoholic beverages. That was an important waiver, wasn't it? Colorado, acceptance of interstate licenses. This also facilitates telehealth. So there have been a lot of relaxation of rules and regulation. When you really have to have our healthcare system respond quickly, you realize how many cumbersome rules and regulations have been in the way of a more efficient, more effective, and more cost-effective healthcare system. And we're working hard with members of Congress and state legislatures to help them see that a lot of the rules and regulations, including certificate of need, that for states really have restricted the supply of hospital beds and the supply of nursing home beds, that if you need more, that the market should be able to know that, not state legislators who may be in the pocket of the people who benefit from not having that additional competition. I also see in this administration that they're really looking at redefining government as a partner rather than an adversary with the private sector. And I had sort of the first conscious awareness of this when I was at a White House Christmas party. And I happened to sit at a table with a person who was a senior official in the Department of Labor. This is not somebody I would have run into in my normal course of dealing with health policy. But he was talking about how they are now trying to, instead of going into mines and sort of doing gotcha with them, they're trying to figure out how can we help mine owners and operators be safer so that they are able to anticipate and stop the next accident, to keep their workers safer and to keep their doors open. And that was really, I thought, just so important to think about government as a partner, because government doesn't have the ability to have produced all these masks, to have produced all of the pharmaceuticals that are coming down the pipe. They have to have the private sector. And if they're working together, getting rules and regulations out of the way so that people can actually do what they do best, the whole system is going to be stronger. And I've seen very positively how that's been happening. And we see also that really has allowed innovation to really come to the forefront. As I said, manufacturers repurposing their supply lines to produce ventilators. The car companies, nobody's ordering a car right now, I guess, or not as many people, and so they're producing ventilators instead. Pillow makers making masks and other protective equipment for medical professionals. So people have looked at, what are we doing? What capacity do we have, and how can we help make this be more effective at responding to this crisis? We see it in hurricanes. You know, Walmart is usually one of the first responders to hurricanes. They've got generators, they've got extra water, they've got fuel, they've got food supplies. They've seen this so that they can, in advance, be able to stock up their stores so that people will have what they need to be able to respond. And we've seen this mega stereo during this pandemic. And it's not just the manufacturing capability, but also these companies and individuals have donated billions of dollars in supplies and actual cash to help people, from pharmaceutical companies manufacturing millions of doses of hydroxychloroquine, for example, to the little diner up the street from me in Leesburg, Virginia, who is actually offering first responders and people who are out working free lunch from 11:30 to 2 every day. They don't have enough customers to keep them open. They want to be able to continue to keep their employees operating. They're still filling requests for people who want carryout. But if you're working and you want lunch, then you can stop by there and get a free lunch 5 days a week. So they're trying to do their part. I donated to a small restaurant that I like in Herndon, Virginia. And what they did with the donation was give several dozen meals to first responders and nurses and doctors at the local hospital. And let's talk a little bit about the pharmaceutical industry. All eyes are right now on Big Pharma to rescue us from this, right? After they have been bashed for years as greedy, corrupt companies, which they are not. I know these people. I know the researchers who devote their lives to trying to find cures and treatments for diseases. And we are seeing right now, I think, the incredible energy and the importance of having this private sector infrastructure. There are now several dozen different vaccines in clinical trials. There are treatments, a number of different treatments. There's not going to be one silver bullet solution to this. We are going to need a range of different treatments and tests and vaccines in order to be able to fully respond to this pandemic. Pfizer, for example, just announced it has partnered with a German company that has a vaccine that seems very, very likely to be able to inoculate people against the coronavirus, COVID-19. And Pfizer, the vaccine is in first stage clinical trials in Germany, just about to go into phase 2. They've started phase 1 trials in the United States. But because Pfizer is so confident that this vaccine is going to work, they already are starting the manufacturing of these doses. Because if it were to be approved in September or October, that's not the time that they could then ramp up supply. They wouldn't have the doses available until next spring. We need them this fall. So they are taking a huge, huge risk in saying, we are confident this vaccine works. And we are going to start manufacturing in 5 different plants. They're closing out whatever they were making, and they're devoting these 5 plants in the United States. Kalamazoo, Michigan is one. There's one here in Aberdeen, Maryland, around the country, that are starting now to massive, huge scale production. So millions of doses, maybe tens of millions, will be available at the beginning of the fall when the virus is likely to start becoming active again after hopefully the summer doldrums. So that's the kind of thing that the federal government doesn't have the resources, doesn't have the skills, does not have the risk-taking capability to be able to do this. We have to have the private sector actively engaged. And for the federal government one of the biggest regulatory changes has been all of the FDA changes that have allowed medicines and treatments and tests to get to the market faster. One of the big failures of government was the Centers for Disease Control early on in January, deciding it was going to be the center for controlling tests. It was going to develop the tests for COVID-19. Well, it failed. But private companies said, we don't think that's going to work, so we're going to start developing our own tests. And in fact, the tests that they developed, there were several dozens of them. And the FDA then tested each one and said, yes, that works, and off they went to the market. But if we would have relied on government, we may still not have a test that works. So we've got to have this private sector energy, and that's really, I think, one of the things that's been demonstrated in this crisis. So let me talk a little bit about the dangers of what I see as the erosion of our healthcare system and how we need to really muster all of our energy to protect the healthcare system. And then I want to talk a little bit about what I think we ought to do to get the economy moving again. So there really is an erosion in the infrastructure of our health sector. Hospitals that have not been able to do any so-called elective procedures. Elective only means that you're not coming to the hospital in an emergency situation to get the surgery that you need. It means if you need a pacemaker, if you need to have orthopedic surgery because you can't walk because of your knees needing a new knee. Those are the things that have been postponed. I've read too many stories about people that are in wheelchairs because they have not been able to get the so-called elective surgery that allows them to actually walk. So we've got to begin to allow doctors and hospitals to do what they do so that they can, in fact, be able to take care of the millions of patients who are not getting the care they need. And patients also are afraid to come into the hospital and their doctor's office. People who need regular injections of drugs, for example, to control their osteoporosis are not getting that treatment, and they are therefore at higher health risk. People are not coming in that may have some suspicion something's not right to get a cancer test. So they're likely to be treated at a later stage in the cancer where the treatment is not as likely to be effective. So we've got to get our health sector opened up so that people who don't have COVID are able to get the care and the treatment they need. I'm also worried millions of people are losing their health insurance because they've lost their job. We have a lot of recommendations about how to give people other options for health coverage. Short-term limited duration plans, employers being able to fund health savings accounts, health reimbursement arrangement accounts, to be able to provide their employees with the resources to continue health coverage. And then looking at what Congress has done so far, and I'll wrap up in just a minute, Professor. Looking at what Congress has done so far, they have really inhibited the recovery by providing such generous unemployment benefits. Not only the check that people would get from the state, let's say an average of about $400 a week, they boosted it with another $600 a week from the federal government. That is twice as much as what many restaurant workers are working, and they don't want to go back to work because that unemployment insurance lasts until the end of July. So they are saying, well, I'm just fine. I'm actually doing better not working. The bill that the House will vote on tomorrow would extend that $600 unemployment insurance bonus to January. So are we ever going to get our economy open if we're paying people not to work? The federal government cannot fund our economy. The economy has to be opened up if we're going to allow this to grow. My colleague, Doug Badger, who's with a senior fellow at the Galen Institute, also with the Heritage Foundation, has done some research about where the problem is. We have got to be much more strategic at targeting public health actions to those areas where we have the greatest problem. Most counties, the majority of counties in the United States, have not had a single COVID-19 death. Not one. 30 counties out of, I think, 4,000 account for half of all U.S. deaths and infections. So that's obviously where our energy should be going. You do not need to close down businesses in Wyoming because there is an outbreak in New York City. We also know that the elderly, are people over 65, are those most likely to die from this virus. 80% of all deaths are people over age 65. Nearly 90% of deaths are people with comorbidities. We need to take care of these vulnerable patients and not do what New York Governor Andrew Cuomo did, which is to say to nursing homes, you have to accept anybody and you cannot test them for COVID-19. If they're infected, you still have to take them. And they have become hotbeds and really sort of death prisons for people because they can't leave. They can't see their family, and new patients are coming in that are infected because staffs are short. You see hospital or the nursing home personnel just cannot, the virus just cannot be contained in that closed environment. We've got to do a much better job of taking care of people who are most vulnerable. And then government also needs to be able to change gears, which it has a very hard time doing. Folks, the curve is flattened. The reason we were flattening the curve, we were not saying this virus was not going to continue to spread. They wanted to flatten the curve so you didn't have an overrun of the hospital capacity. We have more hospital capacity than we need. We have 2 to 3 times the capacity that Europe does. The Javits Center, the military came in and created an entire hospital at the Javits Center in New York that only took a few hundred patients. They had to send the USS Comfort away because it only had a dozen patients or so. So we've got to look at the huge capacity we do have and realize that if we are strategic about who we have locked down and who we need to concentrate our resources on, then we can let the rest of the economy open up. Targeted measures, not lockdowns, are needed. And we are facing the prospect of an economic depression if we do not get this economy moving. People know it. They want to get the economy moving, and we need to use our health sector to do a better job of focusing resources where they're most needed. So, Professor, I'll leave it there and see if we have some questions.
Thank you, Grace Marie. I'm sure there are lots of questions. They're already posted. For those of you who weren't here earlier, you use the Q&A icon, which is located to the side of your screen or perhaps on the bottom of your screen, and we can look at those questions there. I actually want to backtrack a little bit because Grace Marie is somebody who works so closely with public policy on this. You know, there's been talk of leveraging this to try and change our healthcare system to something more like perhaps a single payer or something like that. And I just wonder if you could talk a little bit about whether or not single payer systems are better prepared to deal with something like this. Was our more, I guess, diverse type of healthcare coverage, did that proved to be a difficulty in this case? And, well, I'll let you take that question.
The federal government has, what have we spent so far? We've so far spent more than $2 trillion and another $3 on the table tomorrow in the House of Representatives in order to be able to respond to the crisis. And one of the things the federal government did is say that anybody that's on a public program, their treatment for COVID-19, their testing, are all going to be covered. And so making sure that people know that they can get the care that they need. And private insurers have followed and say, we don't want you to not get tested because you're afraid you have a $50 copay. We will pay for that as part of your insurance contract, even though this has certainly come along a long time after those insurance contracts were priced. And so we can respond much more quickly. But I think even more importantly, let's contrast the United States with Italy, for example. Italy's hospitals, where one of the first outbreaks happened, have been absolutely overrun. And that's because in single-payer systems, they are operating at capacity most of the time. That's why single-payer systems have these long waiting lists for surgeries. In Canada, they actually, one of the think tanks that we partner with, the Fda Institute, actually keeps track of how long the waiting lists are for various kinds of surgeries, seeing primary care physicians, seeing specialists, etc. The average wait time just to get in the door to see a doctor is 16 weeks. If you have a surgery in, let's say, scheduled for early December, and the hospital has run out of money, you're just crossed off the list. I'm sorry, we cannot provide you the surgery because we've run out of money, or we don't have the beds, or we don't have the physicians. So the fact that the United States has 2 to 3 times the hospital capacity of systems that have a single-payer healthcare system should tell us something about what we've already known. If you're sick, you want to be in the United States. You do not want to be in another country. If you want to just feel like, oh, it's just great, the government's going to take care of me and I don't have to pay health insurance premiums, even though I'll pay much higher taxes, that's fine. But if you're sick and you need good care, where you want to be is the United States of America.
Okay. We have some questions.
Can I add one more thought to that? There's actually some research that's being done that will show what is the chance that if you are hospitalized with COVID-19, what are your chances of survival in the United States as opposed to some of the other countries that have single-payer systems. And we're already seeing that if you are hospitalized, then you have a much, much greater chance of surviving if you're in the United States than if you're in Italy, for example, or France, or the UK. Sorry.
Mm-hmm. Well, in some ways, we do have some elements of a single-payer system, don't we? We've got Medicaid, Medicare. I don't know. I think many people do rely on that for their coverage. What have we learned about those programs during this crisis?
Well, one of the Medicaid is Medicare and Medicaid both are run by a friend of mine, Seema Verma, who's administrator of CMS, and she has really taken to heart the idea of being a partner rather than an adversary with companies. With Medicare, since 2000 and passage of the Medicare Modernization Act in 2003, there are a growing number of people, I think now it's up to about 15 to 20 million seniors that are on private plans in Medicare because they find they have better access to benefits, more assurance of being able to see physicians, coordinated care, etc. So we can see in the private plans in Medicare that people really, it's more like a continuation of employer coverage that they might have had through private plans. Medicaid, she is giving states as much leeway and as much flexibility as possible. My colleague Brian Blaze, another senior fellow at the Galen Institute, has done some terrific work. All of this is available at our website, Galen, GALEN.org. And Brian has shown that, yes, Medicaid is a seriously flawed program, and we need to give people an escape hatch. if they are on Medicaid, it's actually more like being in a single-payer system in Europe. You have a very hard time finding a physician who can afford to see you, very hard time especially finding a specialist, and often you have to go to the emergency room just to get routine care. So we need to give people more choices. We're working very hard with a group I work with, the Health Policy Consensus Group, on a plan called the Healthcare Choices Act that would actually be a way of giving people more choices, energizing this private sector economy to respond to the needs of patients, not to the needs and demands of government bureaucrats. I think we are seeing the importance of that in this pandemic crisis, and we hope to build on that foundation. But you're right, there's still going to be people that just say we need to have everybody on the same government system, even though we've seen the failures of that system.
Right, and I did hear a story which I think has maybe been debunked about one of the first teenagers in the United States to die from COVID was refused at a urgent care clinic because he didn't have insurance. Now, I don't know if that story turned out to be true or not, but these are the kinds of stories that, you do hear, and they do cause concern. So how do we address the problem of the uninsured person? They've got symptoms. What happens to that person?
The government has said that hospitals got $100 billion, hospitals, labs, others, $100 billion. And part of it was to compensate them for all their losses, so that they were not having the normal healthcare procedures they've been doing, but also to compensate them to make sure that no one is denied care. So there's ample federal money to make sure that people get the care they need. And if somebody isn't, then they actually have a legal case. They should say, and as we know with EMTALA, anybody who shows up at a hospital needing care cannot be turned away without either being referred to somebody to get the care they need or the hospital providing that care. That's been in effect since the 1980s. So the uninsured, as we all know, are not dying and bleeding in the streets. They get care from the best hospitals in the world, and they don't have to pay for it, and there's separate streams of funding to pay hospitals and compensate them for providing that care. A government-run healthcare system is simply going to underpay all the doctors and hospitals, so we have less capacity, like we see in Europe, and everybody has a harder time getting care.
Well, I want to follow up on the Medicaid issue. As you said, the government has increased spending for Medicaid, and I know that the states run that. Could you talk about whether or not the incentives under the current system are good for states? And I know that some of them have been pushed through because of the emergency. This is a crisis. You don't have that time for debate. But what are some of the long-term consequences of some of the policies that are being put into place recently?
Well, there is a boost in Medicaid payments to the states that is supposed to be temporary. I think that to be honest, I think there's an agenda among people who want a government-run healthcare system that see Medicaid as the platform for that. Even though they call it Medicare for All, they really see Medicaid as the platform. Right now, there are 72 million Americans on Medicaid. So it already has that's about one in five Americans already are on Medicaid. They want to boost funding to states and want to boost it further in this legislation that will be considered tomorrow. In order to funnel even more money to the states, the proposal that Speaker Pelosi offered last week would boost federal funding. As we know, Medicaid is a shared federal-state program, right? The federal government pays, on average, about half of the cost for Medicaid. States pay the other half. States that are poor, like New Mexico, where I was born and raised, get a much higher federal match because they have a much higher poverty rate. But this would bring all states up to almost a 95% federal match. So the states would get $19 for every $1 that they put up for Medicaid. That is a huge, huge incentive for abuse of the program, and we already see it. I mean, games are being played with this program so that they basically tax a provider and say that, you know, we're gonna tax you a certain amount. We're gonna use that money for our Medicaid match, and then we'll give you back some of that money once they've drawn it down from the federal government. So it's just they see Medicaid as a funnel for federal dollars, and then the state often spends that money on roads and bridges. It doesn't even spend it on health care. New York State charges the federal government something like $5,000 a day for some patients in certain care facilities, and then they draw down that money, they spend it on other state projects, and the people in that care facility actually get substandard care. So we have got to stop this. Brian Blaze actually did his PhD dissertation on Medicaid and really exposing the abuse in the program. Seema Verma actually has a proposed regulation out there that would begin to pull back on some of those games states are playing so that the program can once again be the safety net program it was designed to be for the poorest and most vulnerable members of our society. Right now, it's seen by too many states as a cash cow to figure out how can we fiddle with as many dials as possible to get as much Medicaid money as we possibly can. That's not what the program's for, but the legislation that's being considered in Congress now would actually make that gaming worse rather than really trying to reform the program.
All right, I'm going to take a look at some of the questions that have come in for you, and if you like, you can read the questions yourself. That should be at the side of your screen. And so this first one: how does the normal pharmaceutical market differ from the crisis time pharmaceutical market?
Oh, I wish we could have a conversation. So the market is, I think really what we're talking about is the innovation, because the market, you know, for people who are on maintenance drugs or people who need chemotherapy, they still need that. So the supply, hopefully, is going to continue for the people who have non-COVID related challenges. But for the response to the COVID-19 epidemic, it's night and day, because all of a sudden they're talking to FDA about how quickly can we get our product to market once it's proven to be safe and effective. I cannot tell you what a different world that is. Right now, and in the past, it takes 12 years for a drug to go from the test tube to the market. And hundreds of the ones that get in that line don't make it. It's the average cost of bringing one drug to market. Just the investment of the pharmaceutical industry in bringing it to market is about $3 billion. They have to front that money, and the FDA could deny approval at the very end of that process. Now, the FDA is saying, how can we work with you to get these vaccines out as soon as possible? We want a lot of players. Let everybody come to the table. Do your best job. Let's see how we can succeed. It's more like a wartime kind of response rather than our normal hidebound regulatory system. Certainly, Scott Gottlieb, the former FDA director, and before him, Mark McClellan, all of them have really been trying, and Commissioner Hahn now, all of them are trying to break down all of the rigidity in this system. We've got to learn from this and build on this going forward. I think, Professor, there was a question above that, too, that may have come in a little bit, or maybe not. The long-term effects of healthcare. Maybe I'm looking at it from the wrong direction. Do we see that one? What are some of the long-term effects of healthcare because of the postponement of elective procedures? Yeah, I'm really worried about that. I think you're going to see an explosion of people needing care for all sorts of ailments, both because hospitals have been shut down and being able to provide elective procedures. I think a lot of clinical trials bring other non-COVID related medicines to market have been shut down. Some of the companies may have very marginal investor funding and they will run out of funds. I think we'll see some other drugs that might have come to market, or treatments, medical devices not coming to market. And I think especially you're going to see a lot of especially private practice physicians that are just saying, I cannot pay my staff, my office. A lot of doctors already have been taking very little salary so they can keep their offices open, pay their staff, buy the equipment they need, and take care of their patients, which is why they're doctors in the first place. And over this last 2 months, without a lot of cushion and margin, a lot of them are saying they're just not going to be able to open their doors, or they may have to sell their practices to the nearest hospital.
Okay. Speaking of the way that this has affected doctors, similar to the way it's affected professors, and teleconferencing has become a more common means of delivering healthcare services. So the question here reads, with the start of large-scale implementation of telemedicine being used, do you see this as a permanent change in our healthcare system?
I don't think we're going to be able to go back, because I talked with someone who had a handyman that had to come to his house to fix some plumbing or electrical issue. And the handyman knew that this person worked in the health sector. He said, I cannot tell you how much I love telemedicine. He said, I used to have to take half a day off, drive all the way across town, wait in a doctor's office to be able to be seen. He said, now I can go online, I can see my doctor, whatever I need, a test or a prescription, he can prescribe right there. He said, it takes me 20 minutes. He said, please let this stay. And actually, this was a place where the federal government actually led when Administrator Verma said that the federal government for Medicare would pay for telemedicine, telehealth visits. And that also allows people who are afraid to go into a doctor's office to still be able to talk to their doctor. So I think that it's here to stay. Obviously, there are going to be big battles over whether or not doctors should be paid the same amount for a telemedicine visit as they are for an in-person visit. Some doctors may still say you need to come in because I need to see you. But for, what should they say? It's called a physical exam for a reason. You need to be physically there. But I think for a lot of things, and that's where also the ability for doctors to be able to practice in a different state, that's been a real problem with telemedicine, that you have, some states have said you have to actually be a patient of that doctor, have been in their office and seen them in order to be able to have a telehealth visit. Well, that may not work if you need specialty care. So I think we're going to start to see opening up of the lines of what telemedicine can cover. It's been an absolute explosion to the point that some of the companies have just really not even had capacity to be able to handle all the calls they get. But, the free market fixes that, right? They'll figure it out.
I think that's the theme of this seminar. So there is a similar question here. What other long-term changes do you see in the healthcare industry as a result of this? What is the new normal going to look like when we get past this?
Well, I think it's actually going to be a little like the response to the coronavirus. It's going to be different in different places. I think there's going to be more of a demand for deregulation so that each county, city, state can respond better to the needs of their citizens. I participate in a lot of seminar groups, and one of them, one of the members runs an inner city hospital in Los Angeles. She would love to see a single payer system because most of the funding that she gets is from the government. And she said then we would have no uninsured people because everybody would be under the government system. But she said, if we could just have more control over the resources instead of having to jump through all of Washington's regulatory hoops, we know better than Washington does what the problems of our community are. That they aren't always being able to have the latest MRI machine or lab testing equipment in our hospital. She said sometimes it's as simple as being able to do outreach so someone can stay home, so that they have the meals they need, a place to live. If we could partner with other agencies to pool those dollars together to provide a real foundation for some of the people who are chronically in the hospital, there's some patients that will go to the emergency room because they know there's a wait, and they know there's a rule. If they wait long enough, then somebody brings them lunch, so they get a sandwich. It costs maybe $1,000 just having that person come into the emergency room. Let's buy him the sandwich so he doesn't have to come to the hospital to get a meal.
There's another question here talking about the lessons from the financial crisis of 2008 and drawing some parallels with what's going on now. The biggest problem with the 2008 financial crisis was the Fed bottlenecked the emergency funds by being too selective with who received benefits. What solution do you propose to open the economy while keeping the infection rate low?
Well, as I said, I think you really have to be very targeted. Look at those areas that have the highest numbers of infections, that have the highest prevalence of death, and see what's going on there. Focus our resources there on the most vulnerable. That's when we're going to be able to save the most lives. We are losing lives now because people are not getting the medical care they need, because of suicides, addictions, that people are just totally distraught over losing their livelihood, their savings, the business they may have built up for 10, 20 years. That's a huge risk to our society too. And Dr. Fauci, when was asked about this in his testimony on Tuesday, I think it was Senator Rand Paul asked him about this, and he basically said, the economy's not my job. You know, he's focused on what can we do to stop the spread of the virus, and not thinking about the enormous collateral damage to the economy and to people's lives and to families that are trying to keep their business going, trying to work at home where they've got little children at home. And it's just an impossible thing for them to think of doing until the fall or next year, as some people are proposing. So we've got to get the economy going to save lives and livelihoods. And that's, I think, one of the reasons that all this money has been flowing out from the federal government to help people stay afloat. But the federal government can't fund the economy. It only can operate if the economy is working.
So one of the things I wanted to ask you had to do with the Andrew Cuomo's order about the nursing homes being required to accept patients without testing. So that's news to me, and there must be a reason for it. The compassion, what is the alternative to that? It seems like this is a compassionate thing to do, but you're saying it's putting people at risk. Could you explain that a little bit?
Yes, it was I think like the 24th or 25th of March that the executive order went out to the governor's office to nursing homes, basically saying you cannot turn returning patients away. You cannot turn anybody away that comes in needing nursing home care, and you can't test to see if they're infected. So what is that? And where are the majority of deaths in New York are now in nursing homes? In Pennsylvania, 2/3 of deaths from COVID-19 are in nursing homes. They are hotbeds of infection. They did it. The original reason they did it was because they were worried about patients staying in the hospital too long and that they might have a surge in need and there wouldn't be enough hospital beds. So it was a way of getting people out the door of the hospital that had been treated to be able to go back to their nursing home rather than continue to take up a bed space in the hospital. But that was such a false premise. You had the Javits Center that was half empty, the USS Comfort that had huge capacity that was never used. But they couldn't change this. That order is still in effect. The AARP, the nurses unions, all of them went to the governor saying, this is the death sentence not only for many of these residents, but for us as nursing home care workers. We have to be able to determine if the person's sick so that we know how to treat them differently. That was one of the secrets that, not secrets so much, but one of the solutions that South Korea, which has really been very advanced in its response to COVID-19, they tested so that they could isolate the people who were infected into certain centers and isolation facilities until they were well, keeping them apart from both the general population and people who had other ailments. They were able to keep their economy open, and they are able to do a better job of responding by knowing who's infected, treating them differently, and keeping them from being super spreaders. But New York Governor Cuomo did just the opposite, and basically saying to nursing homes, you have to take infected patients as well as new patients. You cannot find out if they're sick, and you have to treat them just the same. And the result has been a huge epidemic of nursing home deaths.
I know that we have taken special care to protect, or at least we're supposed to take special care to protect elderly people. And I'm just wondering, it sounds like from these statistics that we're not being very effective at that. I had heard that Sweden was also taking a similar approach and putting a priority on protecting, and yet most of their deaths have come in the nursing homes. I'm not sure why that would be. Do you have any idea, apart from the executive order, why we can't do a better job protecting this particular population?
The reason people are in nursing homes is not only because they're more likely to be older, but they're more likely to have what we call comorbidities, other problems, heart disease, diabetes. They're much more susceptible to the virus if they are older and have comorbidities. As I said, 90% of the people who died have comorbidities. 80% are over 65. And the greatest number are actually over 70 or 80. And they're more likely to be in nursing homes. So we already know they're the most vulnerable people and therefore need special attention, special care. And yet in New York, New York was not the only state that did this. I think several other states, Massachusetts, I think Michigan, all of them there are at least a handful of states that had similar orders, and they have been the places where we've seen the worst outbreaks. We absolutely must take the best care of people in nursing homes because they're the most likely to succumb if they get the infection. So we've got to protect them. They're the ones that we need to make sure don't get infected in the first place because they're much less likely to survive. And in a lot of states, they have not done that. Other states have been much more effective and got it. Follow the science, follow the data. That's what's so upsetting to this about this to me, is that they're saying, follow the data, follow the science. Well, we're saying, here it is. Listen to who's most vulnerable. Let's focus our energies and attention on them, not on school children, not on the families that are much less likely to get infected and who need to be able to go about their lives so that they can survive economically.
Well, that's kind of a good segue into a couple of questions that were here that expressed a certain amount of doubt about both the media and the government in terms of the accuracy of information, perhaps that it's been overblown, and I don't know that it has. The questioners seem to think that perhaps we've been manufacturing or trying to influence public perception in a certain way. First of all, I don't know what you think about that. Are we getting accurate information from the people that we trust?
Well, Dr. Birx from on the President's Task Force, she said, I don't believe anything that I'm hearing from the CDC. The CDC is still collecting data as though this were the 1970s. People call in their statistics every night. And on weekends, they don't do it as much. So on Mondays, you get a big spurt. Goodness gracious, there are companies out there who are collecting real-time data with unbelievable algorithms using artificial intelligence to collect data so that you have real-time, much more accurate data. So yes, I think that once again, failure of government. Government should be good at collecting data. It is way behind. States' computers, haven't been updated since in the last 40 years. So there's a real problem with accurate data collection. But the federal government has also distorted some of the data itself. If a hospital can categorize a patient as a COVID-19 patient, they get an additional, $10,000 to $20,000 for that patient. If they get put on a ventilator, they get an additional $40,000 for that patient on average. Different payment policies around the country from Medicare. So what does that mean? You have this huge incentive to be able to say that a person has COVID or died of COVID in order to be able to get this additional federal money. So yes, there are huge distortions in this data, which is why it's very difficult to look at cross-country data and to really think you're dealing with the same baseline. You are not. In this country, if you die with COVID, and she's actually said this, if you die with COVID, not from COVID, you're going to be counted as a COVID death, even though you died of a heart attack. Somebody could say that, you were in a car accident and were, a fatal car accident, but we learned later that you were on your way to the hospital to see if you had COVID and you tested positive. It's counted as a COVID death, even they died in an automobile accident. And so that's nuts. Yeah. I mean, we really are distorting the data. The questioner is right. That's another thing we're going to have to get to, is figuring out how do we get accurate data so we can make good decisions about what to do next without shutting down the economy and causing tens of millions, hundreds of millions of people's lives to be overturned.
Right. And the next question kind of deals with people's lives that are being overturned. It's a question about our mental health care system and our substance abuse and other related types of illnesses that are brought about or made worse by stress. How do you see this crisis affecting those systems?
Again, we don't have data. How many people are staying at home drinking or have become addicted to substance abuse or to substances as a result of being at home, being so distraught, distressed? How much more child abuse is there from angry parents at home taking it out on their children? I mean, there's a lot of evidence we don't have. I spoke yesterday on the phone with Dr. Michael Burgess, who's a physician and also a member of Congress from the Dallas-Fort Worth area. He is also the ranking Republican on the Health Subcommittee of the House Energy and Commerce Committee. That's the committee that held a hearing this morning with Dr. Bright talking about the whistleblower. And we were talking about, some of the same data about looking at where the problem is and really focusing on our resources on that. And he actually, as a minority member of the committee, is the top Republican, but he doesn't really have power in the committee any longer, is asked the chairman to hold a hearing to find out what is the effect on mental health of this crisis. We have been so focused on ventilators and hydroxychloroquine and ships and temporary the hospitals being set up. We've got to look at the collateral damage, mental health care, increase in substance abuse, the people who are not getting the surgeries and the cancer treatments that they need. We've got to focus on that, and it is a huge incentive to begin to allow these economies to open up and to allow our health sector to do what it ordinarily does. A lot of labs, by the way, clinical labs, are laying and furloughing workers, if you can imagine, when there are huge demands for more and more testing because they were paid so little at the beginning that they actually lost money on every test. Well, how long could that continue? And so there's a big battle going on over, can these labs, which are mostly private labs, continue to produce these tests while they lose money on every test? And by the way, almost all of the rest of their business for their normal blood work and normal testing has dried up because nobody's going to the doctor. So we've got to be able to get the right balance back in our health sector. And I frankly think that's going to take a long time. Getting somebody to go back into the doctor's office to get their infusion therapy for their osteoporosis is going to take some doing, even though the doctor's offices are taking unbelievable care to make sure that everything is sanitized, that they change their equipment and their robes every single time after every patient. But until the patients go there, they don't know that. So we've got to get this going so the collateral damage, like people that are suffering from mental health problems, I think there's been like a 4,000% spike in people calling hotlines for mental health care. We've got to address this problem.
So I know that people are using the crisis as a political opportunity to advance their agenda. Let me invite you to do the same. If you were to take what we've learned from this crisis, to propose changes to our healthcare system, what specifically would you like to see happen?
Oh, that's great. Thank you for that question. I actually spent yesterday afternoon writing an article exactly to that effect. I run a group called the Health Policy Consensus Group. We've been meeting since I started the Galen Institute 25 years ago. It's the top health policy experts from think tanks in Washington and around the country that specialize in healthcare, and we meet to collaborate and come up sometimes with statements and ideas. We've come up with a plan called the Healthcare Choices Plan. It was designed to be the replacement plan for Obamacare. How do we replace the coverage that so many people now have under the ACA, but that has so distorted the market for health insurance that it's really pricing millions of people out of the system? How do we right that ship? Well, a lot of the things that we were proposing in our Healthcare Choices Plan have been proven to be the solutions now, and that is much more local control. Letting states, which Mississippi has very different problems than Minnesota does, California than Georgia or Florida. That states know, just like this hospital administrator that I talked about in Los Angeles, they know the needs of their communities. When Washington tries to set the rules, it doesn't get it right for anybody. And so we've got to devolve power and control back to the states with resources so that they can do a better job than Obamacare did, frankly, does, of taking care of people who are most need health care, the most vulnerable, and giving states the resources and the flexibility to get their small group and individual markets healthy and working again so that they're selling policies, offering policies that people actually want to buy because it meets both their needs and their pocketbooks, with subsidies for people who can't afford policies. I talked with a woman named Janet from Colorado, who, when we were first developing this plan, and she said, she says, I've got multiple chronic conditions. I've had a liver transplant, and I'm on a lot of medications to begin to be able to sort of to keep track of my illness. And she said she was on a high-risk pool coverage, had high-risk pool coverage with the state of Colorado before Obamacare passed. When Obamacare passed, she lost that coverage because the risk pool closed. And she said, since then, I've had a terribly difficult time getting the care I need. It now costs me $16,000 a year to be able to take care of myself, to be able to get the care I need. And she said, it was so much better before when my state was running a high-risk pool just for the people who most needed it and couldn't get private coverage, She said, but that went away. She said, I want my old coverage back. So we believe states, given resources, could do a better job of creating high-risk pools, invisible high-risk pools, reinsurance plans to provide extra coverage for those people who most need, who have predictably high health expenses.
And
So,
just to clarify, these are designed for people with pre-existing conditions who might have difficulty finding insurance in the regular marketplace.
exactly. And because of that, they wind up driving up costs for everybody else when they're thrown in the same pool. And what happens? The healthy people leave, and the costs go up. When the costs go up, more healthy people leave, and it becomes just a fire underneath healthcare costs that causes it to be so expensive. More than 3 million people have dropped out of the small group and individual market simply because they can't afford coverage. Another man wrote to me who had coverage through in Virginia for his family, $4,000 a month to pay for the care and coverage for his family. He said, how am I supposed to afford that? And another dad said, I had to drop my ACA coverage because I no longer could afford the premiums, but I bought a short-term policy for my boys because I needed to make sure they were protected. A few months later, one of the sons was diagnosed with leukemia. And that short-term policy has paid, last I heard, $170,000 to make sure that child can get the care he needs. And the doctor and the father said, thank heavens for that short-term policy that allowed me to have a different solution for coverage. And this short-term policy was actually something that my colleague Brian Blaze, that rule that helped to get through when he was at the White House as an advisor to President Trump, so that people would have other options. People need other options. So that's what our Healthcare Choices Plan is organized around.
And there's a question here about costs in the American system. We do have the world's most expensive healthcare. You said earlier that this is a great place to be treated and that our COVID survival rates are quite high. And that's all good news. But what about the costs of our system, and what can be done about that?
The costs of our system are so driven by rules and regulations rather than the marketplace. Mark Pauly, who's really one of the deans of health policy and the community professor at the University of Pennsylvania, says that 80% of all healthcare is either directly or indirectly controlled by government of one level or another. We do not have a properly functioning market in the health sector that allows the providers and the insurance companies to be able to provide the kind of policies and the care that people want. You start to see it kind of popping up with doctors doing direct primary care, for example, saying, I'll see you for $50 a month. You can call me anytime. Here's my cell number. I'm your personal doctor, and they can have fewer patients and do a better job of taking care of them because they're not dealing with insurance. Others joining health sharing ministries so that they can basically, with a community of like-minded, often people of faith, but they also could be people that are from the same professional community, whatever, that come together and say, we're going to share medical bills together. We'll pay out of pocket for the routine stuff, but if somebody needs surgery, somebody's having a baby, then we're all going to pool our resources together to take care of them. It's really the principle of insurance, just under a different umbrella.
Okay.
So we need a lot more of that, a lot more choices, a lot more on the ground solutions.
Okay. Well, we're coming to the end of our scheduled event. I'm going to let you have the last word here to deal with the question which was originally raised, which is, what are the lessons that we have learned about our system from the COVID-19?
Well, we have learned that it's a very strong system, and we have been bashed around the world for the United States having the worst healthcare system in the country. When it matters, it has shown we have enormous resources. We have enormous capability. We have enormous flexibility if the federal government will get out of the way. We have enormous compassion to take care of people, to take care of the most vulnerable, and to pool our resources so that we have the ability to do that. We also have learned that our healthcare system is really hidebound, and we have to open it up. And I really encourage people to go to our website, galen.org, look at some of the writings and some of the things that we've been talking about. I do a weekly newsletter, Americans Healthcare Choices, and they can sign up for that on the newsletter so you can see what we're talking about every week. But we work closely with members of Congress. I testify regularly before Congress, do a lot of speaking. We all do a lot of writing. Brian has a piece in the Wall Street Journal about every other week, a lot of papers. But we're really trying to help policymakers with the resources they need to be able to take our health sector into the new world, to create this new generation of healthcare that's responsive to the needs of people, and using the strength and resources and capability that we see are there so that we can not only solve problems with COVID-19, but really help the planet. We already are the engine for medical innovation, for the world. This has shown that we can take this to the next level and cure and treat diseases that we can't even imagine could be taken care of. Curing cancer, for example. If we just let the health sector have the government be a partner rather than an adversary, and believe in the strength of our system, solve the problems in a targeted way, but don't try to tear the whole thing down. There's too much good here.
Okay. Well, that's been a very enlightening hour. I thank you for spending time with us today.
Thank you. Judy, I'm sorry, you probably heard the lawnmowers, the gardeners decided today was the day to come. Sorry for the background noise, but can't help it.
No worries there. And thank you very much. Thank you very much. And now I invite our students to enter their break rooms, where I will meet them, and I will see you there in a few minutes. And for the rest of you, thank you for participating today. Be sure to look at the entire events for this weekend, and I invite you to see us again. Thank you very much, Grace Marie Turner.
Thank you so much, Professor. It was a pleasure to be with you. Thanks, everybody.